Welcome back to the Kimberly Elayyne Show. Today's conversation is an especially meaningful one because it's all about a condition that is often misunderstood, frequently missed, and deeply disruptive to people's lives. My guest today is someone widely known not for just his clinical expertise, but for the way he advocates for patients, especially for those who have spent years being dismissed, misdiagnosed, or told their symptoms don't make sense. I'm honored today to be joined by Dr. Ian Carroll. Dr. Carroll is an associate professor of anesthesiology, perioperative, and pain medicine at Stanford University School of Medicine and the chief of the Stanford CSF Leak headache program. He is a board certified in headache medicine, pain medicine, anesthesiology, and addiction medicine, and he serves as a medical advisor to the Spinal CSF Leak Foundation. He is known for his work in helping shift how cerebrospinal fluid leaks are recognized and treated, particularly in patients whose symptoms don't always show up on imaging and don't fit neatly in perfect diagnostic boxes. Dr. Carroll, thank you so much for being here, and I appreciate you being on the podcast.
Thanks for having me, Ken.
Thank you. Before we dive in, what did you originally study in college, and did you always want to know that you wanted to focus on spinal fluid leaks?
I wasn't always sure I wanted to go into medicine. I studied political science and international relations in college while also doing kind of my pre-med coursework. And then I went into, I worked for a summer in Senator John Kerry's office and thought about maybe going into politics but decided that I wanted to do something where I was less sitting in an office, and ultimately decided to go to medical school. And then originally thought I would do HIV medicine because I went to med school at Columbia in the early 90s. And that was a time when HIV was really just destroying people's lives. And we had just wards of patients, full of patients who were dying with HIV and tuberculosis. And so, my first exposure to inpatient internal medicine was on a ward that had nothing but patients who were suffering from HIV. And so I thought about going into that, and then later switched into anesthesia primarily because of an interest in critical care, and then eventually found my way to pain medicine and long and meandering road.
It's awesome. It wasn't a perfect road, but you got there. I know that
Yeah.
the spinal fluid leaks are personal to you. And in case people don't know, can you explain why that is?
Well, I have a developmentally delayed daughter, and as part of her evaluation, she had a number of lumbar punctures. I think she had 7 total. And after one of them began having chronic headaches, and it took a long time for us to really understand that a CSF leak was contributing to that. And that then got me reading obsessively about CSF leaks, which then got me, not because I was interested in, I didn't think I was going to start a leak service at Stanford, but I was just interested. And of course, because it had happened to my daughter and I saw what a dramatic difference it made when she had been patched. We went from being in the hospital a lot to being in the hospital not at all. And then I started thinking about how it had been missed and how it might be missed in others. And at about that time, there was an article in the New York Times that was one of these Be Well things where they present a mystery case. And after I had been reading obsessively about leaks, the case I thought was somebody who had a leak. And then the big reveal in the New York Times piece was that it was POTS. And I wound up talking it over with some of my colleagues and thought, maybe this person who'd been diagnosed with POTS really had a leak. I mean, she'd had spinal surgery. She had problems with her connective tissue. When she stood up, she had headaches. They had never done an evaluation for a leak. They just stopped when they saw that her heart rate went up when she was upright. It is clear that happens to many people who have a CSF leak. So that got me really thinking about it. And then I started reaching out to colleagues at Stanford Hospital, people who ran the POTS clinic, saying, hey, if you have a patient who has postural headaches, I would really like to see them. And I started reaching out to the Marfan clinic. Marfan's a condition that is characterized by having connective tissue problems that can predispose to a leak. So I started reaching out to the Marfan clinic saying, hey, if you have people with postural headaches, I'd like to see them. And I started reaching out to the headache clinic. And pretty soon there were a lot of people coming, and some of them would get better and some wouldn't. And it just became more and more interesting to me.
Wow, that's incredible. Thank you for being an advocate for your daughter and searching out answers for other people as well after that. Thank you so much. For people
Yeah.
that don't know what a spinal fluid leak is, can you tell us what that is?
So there is a connective tissue bag that surrounds the brain and spinal cord. It goes all the way around the brain and then down the neck, all the way down the back to the tailbone. And it's full of fluid. And your brain and your spinal cord, because they're made out of fat, they kind of float in that fluid, just like olive oil floats on top of water, because fat's just a little less dense. The brain and spinal cord, being made out of fat, largely float in that water and are almost weightless. And this is a system that I guess the body has to help make sure that the brain is healthy in ways we don't totally understand. It clearly provides some buoyancy. It clearly is some kind of waste removal system. It may help regulate parts of the brain and the spinal cord are perfused with blood the right way. It may prevent physical stresses from being transmitted to the brain. But what we do know is that when this bag is either torn, or in the case of my daughter, punctured with a needle from a well-meaning doctor, the fluid can leak out. And when the fluid leaks out, patients get a constellation of symptoms that sometimes are easily attributed to the leak and sometimes not. And they consist of head pain, often described as a sense of pressure, often worse the longer someone's upright and better the longer someone's flat, but not always. Neck pain, even if the leak is down in the tailbone. People get terrible neck pain. They get ringing in the ears. They get dizziness. They get a sense of sometimes fullness in the ears, changes in their hearing, because the inner ear fluid equilibrates and communicates with the spinal CSF. And so when the pressure changes in the CSF, it changes the inner ear fluid. And the inner ear fluid is important for balance as well as hearing. And so those get changed. People often get really severe nausea and ringing in the ears, and also a real sense of fatigue. And what my experience has been is that if you have a known needle in the back and you then develop a characteristic headache that is clearly postural, and you tell your doctor, hey, I had a needle in my back and I have this terrible head pain that started with the needle in my back and it goes away when I lie flat, doctors are generally very good at attributing that to the right cause, spinal fluid leak. But if any part of that is not presented exactly that way, then the ability for doctors to make the right attribution is diminished. So if it's not clearly postural or not reported as clearly postural, oh, it's so much worse as soon as I get upright, it's so much better as soon as I get flat, it's not recognized. If there was an absence of a needle in the back, which can happen, your connective tissue in your knee can tear, your connective tissue in a back disc can tear. Just like that, your connective tissue in this bag can tear, sometimes for no good reason, just like somebody's cartilage in their knee can tear sometimes for no good reason. And you can develop a leak. And if you develop a leak and there was no needle in the back, people often, they just don't make the association. Or if the predominant symptom is one of those other symptoms, nausea, ringing in the ears, fatigue, do people really think about a leak? Often they don't. And there's no law that says that headache has to be the predominant symptom or postural headache. So there's a lot of people who fall outside of the kind of most obvious way this can present. And so it gets missed. And I think that's a tragedy because we don't know everything about cancer or lupus or all kinds of diseases that involve complex cellular mechanisms, but we understand a lot about plumbing. And if you have a leak and you fix the leak, people often get dramatically better. And that's often not always within our abilities.
With a known, let's say, dural puncture or injury versus spontaneous, are the symptoms the same?
Pretty much. As far as we understand them, they really are often the same. So the origin of the tear doesn't seem to make a gigantic difference in the symptoms. There's some data out there. There's a kind of this leak where the spinal fluid, when it breaks out of the bag, can drain into a vein, what we call a CSF venous fistula. Those are particularly hard to diagnose, but there's some data that maybe in some way those may be more provoked by coughing, so that the symptom report of a cough headache may be more common in that kind of group of leaks. But we don't have high quality data to say that really different symptoms give us a different idea of what kind of leak it is.
I was reading your research that you were involved with. I think it was one of your recent ones, and it mentioned something like weightlifting, Pilates, yoga, and those kind of things can actually cause a leak. Am I reading that right?
Yeah. So, except that it's not my research. So
Yeah.
that's a paper that I'm fond of citing that was done by Charles Louis and Dr. Shivink, a pair of leak doctors down at Cedars-Sinai. And they interviewed something close to 90 patients who had a spontaneous leak, a leak without a needle in the back. And they asked them, can you identify what triggered your leak? And 2/3 of the patients, there's a bunch of interesting things about the paper. 2/3 of the patients said, I have no idea. I wasn't doing anything unusual. I was just walking around living my life.
Hmm.
So that's interesting in itself, that like you can develop this kind of terrible long-term problem and have no
Mm.
specific trigger trauma. They're just walking
Yeah.
around doing what they're doing. But the patients really said that they could identify what they were doing and they knew exactly what they were doing when it started. There were some common themes that popped up in those roughly 30 patients. There was a group of patients who said that they were either doing yoga, stretching, or Pilates. So something about that tension in your back that you get when you're stretching, if you
Mm.
have an area of weakness, can cause it to rip open. There was another group of patients that they were bending over to pick up something heavy.
Wow.
And then there was a third group of patients who were generating pressure in their abdomen or chest, sometimes coughing hard, sometimes laughing hard, vomiting hard, pushing for constipation, what we in medicine call a Valsalva maneuver, where you kind of generate pressure in your abdomen or chest. And it seems that for some people with an area of weakness in that bag, that pressure is not well tolerated and can precipitate a leak. So there's some recurring themes that we see come up again and again.
Is there any other like less recognized symptoms, like cognitive symptoms, like memory issues, or I know you mentioned like dementia like state in one of your researches that I was reading.
Yeah. So there's kind of two separate things. One is many people with a CSF leak report some degree of cognitive symptoms. So difficulty with memory, difficulty with word finding. I've had patients tell me that they were driving home from a place that they had driven to several hundred times, like the place where their daughter goes to dance class. And they're midway home and suddenly they don't really realize where they are on the highway. They don't know what exit they're supposed to take. Kind of spatial disorientation, often kind of short-term memory things. They find that their family members are telling them they've already told that story. They can't quite remember having done it. And those things tend to get better as you fix the leak. So that's not really a dementia. That's just kind of like something about their brain not being surrounded by fluid in exactly the right way makes it just not work so well. And then there's a separate group of patients where when they have a severe leak, their brain not being supported in their skull actually sinks deeply into the skull, what's called the brain sagging syndrome, and they can develop things that really look identical to dementia. In fact, a subset of dementia called behavioral variant frontotemporal dementia, which is a mouthful. But we've had just a couple of cases of that here at Stanford, where at least one of them was institutionalized, living in a kind of chronic care facility for dementia. And after being diagnosed and treated, no longer needed to live in an inpatient care facility. His cognition got so much better. It's a preventable cause of dementia. I'm sure it accounts for a very, very small group of the patients who have dementia, but the percent of people that it represents is not really known. We've talked about doing a study here, but haven't been able to really generate interest from our colleagues in the dementia group, where we wanted to go back and look at patients who had early unexplained dementia. So like, it's one thing if somebody gets dementia and they're 80 and, that's so common, you would expect a leak would account for such a small percentage of it. But the really unusual cases of dementia, someone who's 50, who doesn't have a known gene predisposes to dementia, I would expect that if you did a review of their brain MRIs, that you might find a higher incidence of subtle changes that we associate with the leak. And you might be able to screen and find some set of those that had a preventable cause of dementia. To my knowledge, nobody's done that. I think it's a very worthwhile thing to do. I think it could have a big impact, but leaks are perceived as so rare, it's hard to interest your colleagues in doing that. It also, it opens up the idea that some outsider who's not a dementia expert might be able to bring something to the diagnosis of dementia and looking at the MRI that they might have missed, which because these are learned scholarly people, they find preposterous. So they, that's probably, they just think this isn't worth studying.
Wow. They should let you in. They should let you help.
They might, the part, it always takes work on their part to do these kinds of research studies. So they're asking themselves, what's the likelihood this is going to lead to anything important? And if, if it takes work and they don't really understand kind of how it all fits together, they just, they assume,
Right.
how could I have missed something important? How could the neuroradiologist who read these scans have missed something that they perceive as obvious, but in fact is often not obvious?
Wow. I know you mentioned earlier about POTS, that POTS could be a symptom of CSF leak. I know POTS has been going around a lot on social media. I think a lot of people would appreciate your opinion on what you think of that.
So POTS, it's easy to confuse a diagnosis with a syndrome, right? Like a syndrome is a collection of symptoms, which is what I think of as POTS, postural orthostatic tachycardia syndrome. That's what POTS stands for, postural orthostatic tachycardia syndrome. And what that means is there is a group of people who, in response to their posture, when they get upright, which is what that word orthostatic means, their heart starts to race, which is what the tachycardia means. And it comes along with a bunch of other symptoms like feeling dizzy, where 60% of those people actually get head pain. And they often have exactly the same symptoms that we were talking about. They have head pain, they have cognitive issues, neck discomfort, they have dizziness. But the thing that gets them actually going to the doctor and often has the doctor paying attention to them is the symptom of their heart racing. And so this is a clinical condition that afflicts a lot of people, generally affects young women more than others. One of the primary known predisposing factors is having a hereditary disorder of connective tissue. So Ehlers-Danlos or Marfan, where you have a condition where the connective tissue is predisposed to tearing or being stretchy. Now, in POTS, the neurology community, the primary dominant hypothesis for what causes POTS is that there is as yet some unfound single or collection of autoantibodies that prevents the blood vessels from constricting and being regulated in the right way. And that causes this condition. So it is characterized as an autonomic neuropathy. And that is the dominant hypothesis for what causes POTS. However, the symptom overlap is so overlapping with what we know happens with the CSF leak: postural headaches, neck pain, dizziness, brain fog. And we know that CSF leaks happen more often again in these same people with connective tissue problems, because that makes the neuro more likely to tear. That often the diagnosis comes down to this tachycardia, and how much should we rely on the presence of a fast heart rate to say this is an autonomic neuropathy versus this is a CSF leak. And we know that in investigations of people with postural tachycardia, that when they get comprehensive neuroimaging, that a subset of them show signs on imaging of a leak. And we also know that among people who have leaks, there is a group whose imaging is often negative. And so it becomes hard to know for sure when somebody's postural tachycardia might be due to a leak, or might in fact truly be due to some autonomic neuropathy. And I don't think we have a really valid test right now for telling us when a leak has been excluded and when somebody's problem is clearly related to an autonomic neuropathy. So I think there is both a opportunity for misdiagnosis and an opportunity for correct diagnosis, but the wrong kind of attribution. Like maybe you really do have postural tachycardia, but that doesn't mean that your postural tachycardia is happening because of an autonomic neuropathy. Maybe it's happening because when you get upright, your brain sags a little bit, and that puts traction on neural structures that causes your heart to race. So I think that it's a problem because clearly not everyone has a leak, and it can be hard to exclude a leak. And the treatment for a leak is inherently invasive and risky. Somebody like me has to put a needle next to that bag and inject blood or fibrin sealant or do invasive imaging that has radiation exposure. And nobody wants 100,000 young women in this country to go and get invasive imaging or invasive procedures that they may do worse for rather than better. So this is an area where we need research to tell us, like, what is the appropriate way to handle somebody who has symptoms that could be from a leak or could be from an autonomic neuropathy. What percentage of those people should be offered something like treatment for a leak or further invasive testing to look for a leak? And it's an area that I would like to study more personally and recognize that there is the potential for diagnostic confusion. And I think the field is not really clear on what should be done to help distinguish these things and what's the best way to help patients. So that confusion among doctors gets passed on to patients. And I think maybe I'm a little more cognizant of what I think is not known, and I'm maybe a little more comfortable being clear on what I don't know than some doctors who have assured patients that they're not leaking.
You mentioned that not always CSF leaks are shown on imaging. And I can speak from experience because I know you can't say, but you are my physician, and you are the only doctor that believed me for years that I had a leak, and it didn't show on any imaging, nothing. And you talked with me about doing a blood patch to see if that would help symptoms. Can you talk to patients out there who might have negative imaging, who might not even, show the symptoms, but are not being believed because they're imaging and things like that?
All right. So let's start with a group that I think is instructive. So we know that when somebody has a needle put in their back and they immediately develop a postural headache, that we have only one really good explanation for that today. Right now, as far as medicine understands, if you have a needle in your back next to the dura or deliberately put through the dura and you develop a postural headache, the only explanation we have for that today is a CSF leak coming from the hole created by the needle. This is something that was first reported essentially immediately when lumbar punctures started being done. But that's what that's called when you get a needle in your low back. And the inference that it was, in fact, due to a spinal CSF leak was made almost immediately. And for many years, people didn't know how to treat it. And then they discovered that injecting blood in the space outside the bag at the site of the puncture caused many of those people to get better. Okay? So we know that is true. All of what I just said is not controversial. We also know that there is a subset of patients who, when they get a lumbar puncture and they develop that kind of postural headache, that the postural headache continues essentially indefinitely. That is also not controversial. It is clear that some people who have a spinal headache develop that postural headache, and that postural headache continues and continues. And it is also not controversial that when you image those people who were just fine, had a needle in the back, had a known dural puncture, developed postural headaches, and had postural headaches from that day onward, that if you look at them at a time remote from the puncture, talking a year out, 2 years out, their imaging is almost invariably normal. Their MRI of their brain is normal. The MRI of their spine is normal for the vast majority of those patients, at least 90%. Now, different people look at that. So all of what I've just said is not controversial. Different people look at that and reach different conclusions. I have colleagues who I respect who look at that and they say, maybe because the imaging is normal and because they believe strongly that imaging is a very good way to find a leak, they believe that while the early headache must have been because of CSF leak, that now, because the imaging is normal, maybe there's some other cause, that there was some kind of sensitization that happened at the time and that there's no longer a leak, but that there was some sensitization that started a pain process, and the pain process is now independent of any leak. And their reason for saying that is really twofold. One is they say, we think imaging is really high sensitivity and it's not showing a leak, so there must not be a leak, so we have to come up with another explanation. And they say some of these people, when you try to treat them, either with patching or with surgery, don't get better, which is fair. All true. On the other hand, what we know is that if you take these people and you patch them, many of them do get better. Some of them only get better transiently. Some of them get better for 2 weeks. Some get better for 3 months. Some get better for 3 years. But many of them do get better. Number one, suggesting that it's a leak. Number two, at surgery, many of them can have a hole found at the dura, even when the imaging showed no hole. Number three, many of them get better when you then sew that hole shut. So while some people don't get better, many do, suggesting that the leak is an important cause. And when the ones don't get better, you never know, was there another hole somewhere else that you didn't find, right? So my belief is that the simplest, most convincing explanation for this constellation of observations is that there are leaks that are hard to see on imaging, not because the people doing the imaging are not good, not because the radiologists reading the imaging are not good, but because many CSF leaks don't show clear signs of a leak. If in fact you have a group of people who had no leak, you caused the leak, you know that you caused the leak, they've started having symptoms on the day you caused the leak, and they've had those symptoms in an ongoing way, and their imaging is universally negative, and yet some of them are fixed by interventions that only help leaks, surgery, closing a hole or a patch. You have a good framework for believing that there are leaks that are just not seen. And once you accept that, it becomes very hard to say that somebody who developed those symptoms spontaneously without a needle in the back, whose imaging is negative, that you're going to be confident that they don't have a leak because their imaging is negative, right? I have trouble telling that kind of person that they don't have a leak. Now, many of my colleagues would say, but Ian, if you believe that, you're opening the door to doing invasive and high radiation imaging and or patching, which is very invasive, to just so many people where it's hard to tell, are they leaking at all, that you're going to do more harm than good because you're going to be giving patches and doing treatment to all these people who don't have leaks. And I think that's a straw man argument. I think there is a potential for doing that if you said, well, we're going to just patch everyone who has a chronic headache or has chronic fatigue. And I'm not espousing that. I'm saying that we should be honest that we don't really know based on the imaging who's leaking or not. And we should take into account more things than just their imaging when we decide who we should patch. And in our experience, when we in fact patch people whose imaging is negative, we see modest long-term improvements in quality of life, in headache, in a variety of things, fatigue. And so I think this lends to the idea that in fact, many people really are leaking whose imaging is negative. We need to get better at offering them treatment and diagnosis.
Thank you so much for explaining that. People might not know what blood patching is. Can you explain that real quick for us?
Yes. So the dura is the connective tissue that makes up the bag that contains the spinal fluid. So the spinal fluid that's inside the dura is intradural, and the space and fatty tissue that's outside the bag is epidural, outside the bag. And as I mentioned earlier, it was known for many years that if you put a needle intradurally, that some percentage of people would develop postural headaches, often chronic headaches, that would just stay. And at some point in the 1950s, it was observed that when they stuck a needle into the bag and there was a blood in the spinal fluid that they aspirated, that the likelihood of getting those headaches was less. So people kind of looked at that, and maybe some people thought maybe that's because the blood is clotting over the hole. And then to kind of test that, at least one group, when they did these spinal taps, they took some suture and they threaded it through the needle and then took the needle out over the suture so that the suture would just be sitting there in the hole, occluding the hole, right? And sure enough, those patients got no headaches, all right? And the problem was that the surgical suture was made from cat gut, it's made. And that is an inflammatory material. And so while they got no headaches, a number of them got severe neurologic problems with the nerves going down to their legs from the inflammatory reaction from the cat gut. So they quickly abandoned that. But in the late 60s, or in the 60s, a guy named James Gormley, who was an anesthesiologist, decided that he would inject blood around the hole in the epidural space, not in the bag. He'd put a needle in outside the bag, and he would inject semi-clotted blood into that space. And that was the first blood patch, and he observed that it really helped some people with postural headaches, but he did not write up his results at first. And then he developed, this is before MRIs existed, he developed severe sciatica with pain radiating down his leg, what was suspected to be a bulging disc. And at that time, the way you diagnosed bulging discs was doing a CT myelogram, where you inject contrast into the bag, and then you get a CT scan. And so he had that kind of medical procedure. And afterwards, he had a terrible postural headache. So he talked to one of his colleagues and he said, listen, I've been doing this thing where I inject blood over the hole for some of my patients. Could you do that for me? And so his colleague did it to him. And so he became the 9th person who had an epidural blood patch. And then he wrote it up, the cases that he had done, including himself, being straightforward. This is what I did. I did it to myself too. And he sent it in to, I think, the British Journal of Anesthesia. Nobody really commented on it. or picked it up or decided to do it. It just sat there for a decade where nobody cited it, nobody reported that they did it too. And it's kind of interesting how sequestered knowledge really was before the internet. And then in the early 70s, I think in 1973, somebody kind of, it's not clear to me if they came across his paper or they kind of decided on their own to try this, but they did it for 3 patients. Instead of reporting it in a British Journal of Anesthesia, they reported it in JAMA, the Journal of the American Medical Association, which is widely read. So they did only 3 cases. They cited his earlier work, Dr. Gormley's earlier work, saying, look, we're aware of this other report of somebody doing this. But once they reported their 3 cases in JAMA, within 2 years, there were maybe 20 papers saying, we've done this and it really works. And since then, all kinds of variations have been written about it. And it was later applied to people with spontaneous leaks. But it clearly works. It clearly causes many people spinal CSF leaks to seal, especially if it's done early in the leak process, and has become one of the mainstays of therapy for people with CSF leaks.
Oh, I couldn't hear you. Sorry, it cut out for a second. Are you still there?
Sorry, I said become the mainstays of therapy for people with CSF leaks.
Thank you for explaining that. I had no idea the history of it and the fact that he was doing it and got it himself. It's incredible.
Yeah. This would fall into a category of things that many people are skeptical of, and they get like, there's one person who believes in it and they decide to do it on themselves, and it leads to a great advance. And I think there's other famous cases of this kind of thing. I think the first heart catheterization was somebody who did it to himself in his arm.
Wow.
Threading a catheter up his arm into his heart. And I think the discovery that H. pylori, this kind of bacteria, causes duodenal ulcers was really proven by somebody who swallowed a whole bunch of it and gave himself ulcerative disease to prove that was the cause. He later got the Nobel Prize, but no Nobel Prize for Dr. Gore.
They're committed to the cause. I like it.
When you do it to yourself, you're a true believer.
1 second.
Yeah.
The fibrin patch, that's with glue.
Yeah. So there is something called a fibrin sealant. And what that is they take donated blood, they purify the clotting factors, the clotting proteins from the blood. They purify them, they concentrate them, they heat them and treat them in a way to make sure that anything that's in there, like a hepatitis virus, gets killed. And they test it for all the things they know how to test for. And they then have that produced as a commercial product that surgeons and people like me can use to help seal things like the dura during cases. And so we will use that also for patching. It forms a stronger clot than your natural clot. It becomes watertight more quickly. It clots much faster, but it does not spread as well. And so you need to really be able to find the leak or have an idea of where you think the leak might be to use it effectively. And much fewer doctors are kind of trained in how to use it and have experience with it.
And another question I thought of off the top of my head was that I know that you recommend some certain needles if somebody has to get a lumbar puncture. Do you recommend, like if somebody's going to go in, can they say, hey, can you use this versus this?
Yeah. So 2 kinds of punctures. There's the punctures that we want to happen deliberately, and there's the punctures that are inadvertent that we're hoping never would happen, but happen anyhow, right? So the deliberate punctures are when you're getting a lumbar puncture in the emergency room, a so-called spinal tap to look for meningitis, or you're getting a spinal tap to get chemotherapy into the spinal fluid, or you're getting a spinal tap because you're getting something like this myelogram I talked about earlier where they inject contrast. It is clear that when you have a deliberate puncture, that if they use a kind of needle called a pencil point needle, which is a needle in which the tip of the needle comes to a single solid point, and the aperture, the opening of the needle that allows whatever you're injecting to get out, isn't actually at the tip of the needle. It's displaced a little further back the needle, and the opening is kind of out the side of the needle, so that there is a solid conical comb-like tip that enters the dura. And then maybe, a millimeter or 2 millimeters back behind that is the window, the opening to the needle that allows fluid to get injected and come out the side of the needle into wherever you're injecting. And for reasons that are not easily explained, that kind of needle causes people to have only about half as much of these kinds of postural headaches afterwards. The defect that it causes in the dura more easily seals on its own. And this has now been extensively studied, literally hundreds of studies, randomized trials, and meta-analyses in big journals. There's a meta-analysis in The Lancet from 2018 showing that you reduce the rate of these kind of especially in the acute phase, these post-puncture headaches by over 50%. And so I would never let somebody puncture me without one of those needles. There is no downside to using one of those needles. They do not result in higher rates of procedure failure. They cost about $14 more per needle. And still at the same time, most lumbar puncture kits come with the other kind of needle where the tip comes to a sharp point where the bevel and the injection surface is at the very tip, which is more of a historical artifact. And this should really be changed and stopped. So that's one of the things I've been working on at Stanford. The neuroradiologists at Stanford no longer use those cutting needles for our myelograms. The interventional radiologists at Stanford no longer use the cutting needles. They're both using the pencil point needles. But there are still cutting needles being used in the emergency room at Stanford and other places to do lumbar punctures, and it's a problem.
Does the patient have the right to ask for that in like an emergency
Absolutely.
room? Okay.
Yep.
Wow.
Yeah. I think there's real ethical issues there. If we know that these post-puncture headaches can happen, and a lot of times the patient gets told this is a risk. And then when it happens, the patient knows they were warned about it, but the patient isn't necessarily told, by the way, we didn't use the needle that could have made this less common for you. And that this was most likely a preventable complication. And maybe the reason you've got it is because we didn't use the needle that was better for this. And we didn't use it because of X or Y or Z reason. But it's a kind of semi-preventable complication. I don't know that patients are usually told that this happened to them for reasons that could have been prevented.
Yeah. I got my leak from an emergency room visit, and I was never told that. Like it's just thing that they don't tell you. I want to make sure. Let's see. Okay. I want to get to some questions and answers. That's okay with you?
Okay. Sure.
Somebody wants to know, if they're let's say they're in a small town, or they don't have the resources, or they're just starting their journey of thinking, hey, I might have a leak. Is there things that they could try to test at home? Is there things that they should tell their primary? Is there a certain specialist they should see if they can't see someone like you?
They should try to get an MRI of the brain and the full spine. And there's a way the MRI can be done that's important that the doctor will probably not know, and that the MRI, the radiologists at the local center may not know and have as a kind of pre-formatted way of scanning. Because it turns out the MRI scanner, it can be used 24 different ways to get different images. So what they want to get is something called a D acquisition sequence that is T2 weighted and fat suppressed. So that would be something like a T2 cube, CUBE sequence. And so what that does is it acquires the data not as a plane and then another plane and then another plane where there's pixels, but it captures the data volumetrically in a 3D way, where instead of having a pixel, which is a two-dimensional dot, you have a three-dimensional teeny little cube. And when you get that data volumetrically, it can be reformatted and presented in 1 millimeter cuts every 1 millimeter. All right. And so what you want is to have that kind of fine cut 1 millimeter MRI in the axial plane and in the sagittal plane. And you want that sequence, that highly T2 weighted 3D acquisition sequence with fat suppression, because the other critical aspect there is your typical MRI. If you hurt your back and you go get an MRI, there will be a T2 sequence that makes spinal fluid bright, but it will also make fat bright. And I already mentioned earlier that the bag is surrounded by epidural fat. And so if a little bit of fluid leaks out, you're looking for that bright signal outside the bag, but normally there's fat outside the bag. And on that typical sequence, fat's also bright. So you need to tell the radiologist ahead of time that we're looking for a CSF leak, and we want to do this kind of sequence where the fluid's very bright and the fat is made dark. They can do that with fat suppression. They know how to do that. They just don't know that they need to do it. And they don't necessarily know that these 3D acquisition sequences are better than their typical 2D sequence where it's here and then they do another slice 4 millimeters away and another slice 4 millimeters away. You want that 3D sequence and you want the cuts 1 millimeter apart. And you got to hope that you're lucky and you find that. Now, even that kind of sequence doesn't show most of the people's leaks. If they have a post-puncture leak, it shows very few of those. And it doesn't show any of the leaks. The spine sequences don't show any of the leaks if you have one of these CSF venous fistulas. I think I'm increasingly of the opinion that finding, being able to really get this dealt with in your local regional place is just impossible. You really have to get referred to a specialty center. And that's a hard thing. It's a hard thing. The expertise on this has gone further than the dissemination of that expertise has gone. And, I try to do things like this, go to meetings to talk about these things, to disseminate that information. But the realistic likelihood, if you're living, in a place where you don't have access to Stanford or UCSF and you're going to get the right kind of evaluation, is low.
Right.
I would say even before bringing it up with the doctor, you've got to kind of become an expert a little bit yourself, going to the CSF Leak Foundation website, really becoming educated. What kind of MRI do they need to order? What is a CSF venous fistula? All these things. We don't know. There's only like one small study that looked at like 4 patients and it didn't find a big difference between upright MRI and flat MRI, but it was only one study. It was only 4 patients a long time ago. Whether, in fact, more advances could be made with upright MRI today is an open question.
Do you still do the 48-hour test and the blood work? I think it's blood work for like the prolactin. I know when I saw you, we did that kind of thing. And I'm just wondering if you still recommend doing that.
So we know that some subset of people with CSF leaks have elevated prolactin. I do not routinely test for it now because it wasn't changing my practice really when I would see it or when I wouldn't see it. I do, we do have people do what we call a 48-hour flat test. And what is that? That is a test in which we ask people to record their core symptoms of a CSF leak, typically on like a Friday night after being up all day. And so they record on a 0 to 10 scale, head pain, neck pain, nausea, difficulty thinking, ringing in the ears, and fatigue. They give themselves a 0 to 10 scale number on each of those different symptoms. Then they go to bed, they stay flat all night. In the morning, instead of getting up and starting their Saturday as typical, they go to the bathroom, they get back to being flat. And the reason for this is some people with a CSF leak, they have to be flat a long time before their symptoms get better. And maybe they're used to having a pattern where their headache comes on at noon every day, but they just attribute that to a circadian rhythm thing. And so we're trying to separate circadian rhythm from posture. So we have them stay flat all day Saturday. You get up to go to the bathroom, you get back to being flat. And then they do that again on Sunday. And then on Sunday afternoon, before they get upright, they give themselves that 0 to 10 recording again for each of those symptoms. And so you get to see, did they really get better when you stayed flat for a long time? And that can be more convincing than telling your doctor, oh, I feel better when I'm flat. Like, that's one sentence that the doctor doesn't really have to pay attention to. But if you bring them numbers and you say, look, these are the symptoms that I have. I have all these symptoms of leak, and they all get better when I stay flat. And then, by the way, when I got up on Saturday afternoon, I recorded those numbers again after being upright for 2 hours. And this is how quickly they went back to being terrible. That gives you something to focus the doctor's attention beyond the negative report from the MRI. So they can say, look, I've got this negative report from the MRI, but I've got this patient who hasn't responded to a CGRP antagonist for their headache. They haven't responded to Botox for their headache. They haven't responded to Topamax for their headache. But when they stay flat, their headache gets dramatically better. Maybe I can argue for this patient to have a trial of an epidural blood patch. And so that's how we use that. We need to publish data on that. But we do still have people do that, and I still use it extensively.
Thank you. Couple more questions. I know somebody has Ehlers-Danlos syndrome. Their MRI is negative, and they don't want to do a puncture in their back because it could cause another leak. Is there any other testing that this person could do to confirm a spinal fluid leak?
The MRI is it. That's it for non-invasive testing. So you can do that, and you can say, look, without causing a puncture, you could try to treat, like with a patch, and see, right? Some of those people get better, some don't. That kind of patient, I often find that if you patch them and they get better, even if they get better for 4 weeks, like if their headache gets, 80% better for 4 weeks. When it comes back, their enthusiasm for pursuing a leak and my enthusiasm for pursuing a leak has changed, right? Like, once they've actually felt better in a dramatic way for a long time, when nothing else has worked, and then they see something like a patch worked, the risk benefit calculus of going forward with a myelogram to try and better track down where that leak might be, to try to nail it down more definitively, where should treatment be directed, that becomes a different calculus, right? And conversely, if you patch them and it does nothing, well, you can check that off the list, move on to other stuff, right?
Thank you. For
Yeah.
somebody who's fluctuating between high and low ICP, is there can that be a leak, or you seen anything with intracranial pressure?
So ICP stands for intracranial pressure. And there are people who do fluctuate between feeling the symptoms of a low pressure headache, a CSF leak headache, which is a headache that is generally better when flat and gets worse the longer they're upright. But then at other times, often especially after patching, they may experience episodes of time where they show rebound high pressure, which is a constellation of symptoms. The head pain is often more frontal, often worse when flat, sometimes wakes them up in the middle of the night. And these are very challenging patients to treat because they can go between one and the other. And we don't really have concrete evidence about what causes that. We have ideas. My own view is that those patients are usually best served by continuing to try to figure out where the leak is, treat the leak, so that you stop the low pressure symptoms. And then you can give them medicines that reduce their CSF pressure so that their high pressure stuff gets better treated. But it's hard to do that when they're still leaking because, of course, you make their low pressure symptoms worse.
And finally, just my question. I had an interview recently with Dr. Leonard Weinstock, who specializes in mast cell activation syndrome. And he was talking about mast cells being on the dura, on the brain. And I noticed that when I'm in like 10 out of 10 pain from my spinal fluid leak, if I take Benadryl, the pain lessens a little bit. Do you know if there's a correlation of like if you calm that kind of thing, if it helps the spinal fluid leak, or any sort of research in that way?
Well, Benadryl is an interesting drug. If you go back and you look at Benadryl, it was discovered and derived from medications that were first used as antipsychotic medications that affect a lot of different, and you can look this up on Wikipedia. It's really interesting history. There's a tie-in between Benadryl and antipsychotics and antidepressants that are later developed. A lot of them are developed off the same chemical structure. So these are drugs that do a lot of interesting things. They stabilize, they block histamine receptors, and there's a tie-in to mast cell stuff there. But they do a lot of things. So it's hard, number one, to make the inference that the relief that you experience when you take Benadryl is necessarily because of some way that it interacts with histamine or mast cell activation. It does seem that many people with leaks develop symptoms that seem to be attributable to perhaps a higher vulnerability to allergic things generally. And we seem to see more allergies in many of these people. This has not been rigorously explored with research. I have wondered, and again, this is conjecture as opposed to some of the other stuff where I've told you, we understand this. So I will give you conjecture, which is just me speculating, that when you have a hole in the bag of fluid and the CSF is leaking into the space outside the bag, that space it's supposed to be in the spinal fluid is an immune privileged space. There are things that are outside the bag that are not supposed to get into the bag, and there are things in the bag I think are not supposed to get out of the bag. And I think that when your immune system, as it exists, sees spinal fluid leaking out, I think it does something to activate the immune system that's not normally supposed to happen. That is a conjecture that I've thought about to explain this kind of confluence, but I don't think we know for sure.
Thank you for expressing. One last question for you. Are you excited for any research that you're doing or anything new for you that you're working on?
I am excited about things that we're doing where I don't want to go into too much, but we are looking into ways to develop non-imaging objective markers of when somebody has a leak using metrics that functionally measure brain activity so that we can say, look, it's not just that this patient is reporting X or Y or Z when they're upright, but we can measure actual brain changes when they're upright that we see in people who have imaging proven leaks that we don't see in people who are normal, healthy controls, and start to apply that to people who are symptomatic but have negative imaging so that we can say, here's a test that when we do it, maybe predicts who's going to respond to treatment or who is likely to have a positive imaging finding if, in fact, we go forward with a CT myelogram. So that patient with POTS who says, I'm afraid of getting a puncture to go and look for a leak, we can say to them that you have these kind of changes in your brain that predict that if we do this kind of imaging, we're more likely to find something, it's not just a 1 in 10 likelihood of finding something. We can tell you that with these kind of changes, our likelihood of finding something is 6 out of 10, right? So they know they're more likely to benefit than not. So I'm excited about that kind of stuff. I'm excited about a lot of stuff that I'm not involved in. There are an increasing number of radiologists that are interested in leaks, that are working on better ways of imaging. These are people like Andrew Callan at Colorado, the group at Duke, the group at Mayo, at Cedars, constantly pushing the forefront forward on how to better image these leaks. I'm encouraged by advances made at Cedars, advances made at Mayo. I think this is a time when it's real to be hopeful when you have a leak and you have these symptoms that better stuff is coming.
Thank you so much on behalf of the community for fighting for us and for being an extraordinary doctor. I know this conversation will help a lot of people, and you are so valued. We appreciate you so much. Thank you for the conversation today, Dr. Carroll.
My pleasure. I'm happy to
Mhm.
be useful in the world, right?
You are very useful. Thank you so much. Have a good day.